First, roll call. Susan Bartley. Present. LaRon Coleman. Present. Colleen Crossy. Here. Ann Erickson Galt. Here. Benjamin Greenwald. Sarah May. Tanisha Moore. Michael Spitz. Pamela Turan. Present. Dennis Yeager. Could I get a motion to approve the board meeting agenda?
Second.
All those in favor?
Aye.
Is there any comment from the public? So one of our dear board members who's been with the board since the inception of it has passed away. So I'd like to read a short devotion to her. Shelley was instrumental in me being on the board. She asked me to join, and she also nominated me as board chair when she had to resign from the chair position, but she still remained on the board. But we observed the loss of Shelley Goodman Taub. She resided in Bloomfield Hills, Michigan, and departed on February 4th, 2025, at the age of 85. She was born in Detroit in 1939 and received a BA in education from the University of Michigan. She served on the Oakland County Commission for 20 years and also in the Michigan House of Representatives. As commissioner, she chaired many activities, including the Prescription Task Force, the Children's Summit, the Senior Summit, and authored legislation amending child protection laws. She was a founding member of Women Officials Network, Oakland County Human Trafficking Network, and the Jail Diversion Task Force, and was also instrumental in the transition of substance use disorder services from the county to OCHN in 2014. Shelley was instrumental in establishing this board, the OPB, the first Substance Use Disorder Oversight Policy Board in Oakland County in 2015. She served as the chair of the board and contributed much service to the board as chair for 6 years and a member of the board for 5 years. Shelley was a force to be reckoned with. She was a tireless advocate for individuals and a devoted public servant. She will be deeply missed by all. All right, updates from Committee of the Whole by Sarah, who's not here. Legislative updates, Francis Carley.
Hello, good afternoon. I'm Frances Carley, the Director of Strategic Initiatives at OCHN. I am taking over the legislative and outreach kind of component from Christine Burke, our former Chief of Staff, who just recently retired. So it's very big shoes to fill. So I hope to be responsive and provide as much feedback as and information to help the board as as possible. So with this update today, I have a few points I wanted to cover. The first is the OCHN's annual needs assessment is underway. We received over 835 responses from people receiving services and people in the community. And so we will be using that as the foundation to build out the annual the next strategic plan, which will cover FY26 through FY28. I believe those slides are included in the board packet today, so you can look at that for more information. And then the advocacy for federal funding, and the public behavioral health system. That is, as everyone is undoubtedly aware, we're facing some uncertainty and potential cuts in funding at the federal level, which will undoubtedly impact the state and localities. So with Medicaid, we're working generally with CMHA and the other PIHPs to unite, come together on a united message, and really fight for parity for SUD treatment, Medicaid services, all behavioral health services, fight for that parity with the physical health services. And just historically, what we understand from our advocates that a lot of times in the past with potential cuts, the behavioral health services potentially take a bigger hit, I guess, in those terms. And so we're trying to unite and get everybody on the same page with understanding the importance of these services, the continuity of services for individuals who are receiving treatment. And so that message is really at the forefront of what how we're approaching the advocacy. As you're probably aware, some federal grants have been cut, and that has impacted OCHN, and I believe also the county had some grants that were also affected. And Megan, I believe, will be covering some of those details in her presentation coming up, so I won't go into that in any more detail. Then I also wanted to share, and you may have seen it in the board packet, the local justice and SUD partnership kind of overview. The communications team worked, and Christine worked on pulling this together with the justice team and Megan, and so this just points out the cost comparison, service comparison, what the impacts are for SUD treatment services, and what that means for the justice system in Oakland County. And so you'll see the cost per person per year for treatment is about $4,800, and that compares to a cost that could run upwards of about 10 times that, $34,000 to $48,000 for incarceration. So that is something that we are circulating and sharing for advocacy and awareness in the community, and it's a very important comparison in terms of what the services mean for the community. And as part of that, so I also wanted to point out the board packet includes our CEO, Dana Lazenby's quarterly update to the Board of Commissioners, which took place earlier this month. And along with that, Dana has been working on a lot of local and state outreach. I believe Christine updated you on the legislative breakfast that OCHN held in January. And so building on that momentum, we've been working with our legislative consultants, and Ms. Lazenby has been meeting with the local legislators, the representatives from the state and House, as well as the Board of Commissioners, and particularly new members who may not be as familiar with the system, the services, and the level of service needs that some of the folks that receive services here are in need of. And with our consultant, he helped organize a meeting between Dana and Director Hertel from MDHHS to talk about the services in Oakland County. So we are planning to continue that kind of outreach and that conversation, and to understand particularly what the state and how OCHN, how Oakland County can all come together to be on the same page with these potential federal changes looming. And so we've been working on building those coalitions and having those conversations with the Board of Commissioners and the state representatives. We're also building out talking points and an approach with CMHA and the other PIHPs to see how we can most effectively advocate for the populations receiving services and to provide that also education for people who might not be as familiar with the services. So that's really the core of our messaging right now. We're advocating for stability in the system. We're advocating for the service network and education on the intensity and the importance of continuity of service for the group of people receiving treatment and services here. OCHN has been around for 60 years. We're part of this long and strong service system in Michigan, and so we're very much aware of the impact and what we can deliver. So I am available for any questions if anyone would.
No, I guess we're all set.
Okay.
Oh.
Okay, so your title is Director of
Strategic Initiatives.
Okay, so I know that Christine Burks also had a community outreach. Was it just renamed, or was it divided into another position?
Well, my position, I've been in this position. I've been with OCHN for going on 4 years now, and so I was already in this role of strategic initiatives prior to Christine's departure. And so my team and I do a lot of grants, proposals, different service initiatives, and so this component of the legislative outreach is resting with me now. I do have a background. I worked for the State Senate Fiscal Agency for 5 years on the Human Services budget. I also have experience working at Mathematica on CMS contracts and doing project management. So I have that kind of healthcare and budget advocacy and the experience working with the federal government as well.
So in Christine's role as Chief of Staff, she also had the communications department that sat underneath of her. And part of I think the updates you're referring to is that the community events and outreach that come next on the agenda. Yep, Suzanne will still be coming up to do that, and Frances is covering the legislative updates moving forward.
And just I'm Sheila Bear, Executive Strategic Assistant to the CEO and Board of Directors Liaison. And part of the answer to that question is also the Communications and Outreach Program that was previously under the leadership of Ms. Burke is now tentatively under the CEO office.
Thank you.
Were there other questions? Did you? All right, thank you.
Thanks.
Next, we have community outreach updates with Suzanne Weiner.
Good afternoon. Suzanne Weiner, I'm the Director of Communications and Community Outreach. And as Megan just mentioned, that was what she had talked about, that Christine Burke was the chief over that role. So she kind of covered the legislative piece of it, and I covered the outreach and the events that we have coming up. So I'm just going to go ahead and cover a couple of them that we have coming. So if you want to go to the next slide. Just giving you a glimpse of the flyers of information of what we have coming next. We have our Veterans and Community Resource event that is coming up on May the 10th. That's a Saturday. It's from 10 to 2, and it's going to be here in this building. It's going to actually cover most of the building. We'll be in this room. We'll also be in some of our other rooms as well as throughout this this floor. There's going to be a lot of activities going on for that event. We're going to have a couple of speakers in this room talking about the neurocognitive issues, as well as some information about veterans benefits that are available, as well as there'll be some firearm safety training going on. We'll be handing out a lot of gift cards and resources, as well as gun safety boxes. And lunch will be provided. We currently have almost 200 people registered for the event. We have about 40 vendors that are registered for the event, so it's going to be a very active day for us here at OCHN. We're really looking forward to that. You can see the contact is our Veterans Navigator if anybody has any questions. We are still accepting individuals to register at this point. We're doing some additional outreach and media to promote the event as well as the services. We want to make sure that people are aware of our Veterans Navigator and the services that they offer here at OCHN. Also wanted to mention we are hosting our 3rd annual community baby shower. We've hosted that the past 3 years at Welcome Missionary Baptist Church, and that's going to be on Wednesday, June the 4th. It's from 10 a.m. to 1 p.m. And also wanted to mention we were awarded a grant so that we could purchase some additional resources for this event coming up. So we're really looking forward to it. It's basically an awareness event for women, especially for women in the specialty populations, and also to encourage recovery and treatment as needed. But there are a lot of different speakers, different vendors, resources and giveaways that are going to be available to expectant moms, current moms, families, individuals in the community.
And with part of the grant funds that we received, we will also have translators who are on site for those who are Spanish speaking, for them to be able to understand and engage in the presentations and what's going on. So it's very exciting. This is a grant that we received outside of our MDHHS grants. So the SUD team on our Women's Specialty Coordinator and Beth, our grant coordinator, they specifically wrote for this grant and were awarded it to help cover the costs. And essentially it's going to pay for the entire baby shower, all of the resources, and especially the giveaways that we'll be doing, pack and place, things like that. So it's very exciting.
That's all I have. I don't know if anyone has any questions.
If a mom or whoever wants to attend this, but maybe they live in Wayne County, is that permittable for them to attend?
Yeah, we don't check what communities.
Don't check IDs.
Yeah, we don't check IDs. Yeah, exactly. I guess that's the way to put it. Sure. Yes, anyone is welcome. Thank you. Anna's going to clarify.
Okay.
Good clarification. So just to clarify, to speak a little bit more on that, anyone from any county can attend. I do let individuals know as of right now, most of our vendors are from Oakland County, but our grant was actually who awarded our grant is through our perinatal collaborative. So it's for Macomb, Wayne, and Oakland. So those funds could cover all those. So we are trying to outreach to have vendors from all 3 counties so that we can include more of those women as well.
No, you're good. We always want to make sure that we're a resource throughout the whole Tri-County region because people do cross borders, and we want to make sure that if they maybe live in Oakland County but work in another county, they're aware of those resources, or they live, it's important for us to make sure that everyone's aware of the resources throughout the Tri-County region, and we are working with our counterparts in other areas, Macomb and Detroit-Wayne, to make sure that those resources sort of cross borders so that people have the resources they need and they understand what's available to them. Thank you.
Thank you. We have the director's report with Megan Phillips.
Good afternoon, everybody. I am joining on this side today. Usually if I'm speaking, it's for shorter amounts of time, maybe a few minutes, or providing clarification. Because I'm doing a larger presentation with a PowerPoint, it's easier for me to be able to see the board and talk to you and be able to look around to sit in front of you in this manner. So today I'm going to give a nice high-level overview of our SUD system, starting with prevention and moving into treatment. I ask if you would please jot down any questions that you have during the presentation. There is a large chance that I will answer questions later on in my discussion pieces, so I'm just asking all questions be held to the end, and then we can get to all the questions at one time. So next slide. All right, so our SUD department, we're a department of 9. We oversee our treatment and prevention providers. For treatment, it's the clinical programming, and we ensure contract compliance. There's 9 members of the team. There is a director, a manager, a lead clinical analyst, 2 clinical analysts, a prevention coordinator, an SUD health home coordinator, a grant coordinator, and a support specialist. So we are a small but mighty team. I always like to say we move very fast. When decisions are made, we implement and can stand things up pretty quickly. Part of what we also do every 3 years is we conduct a 3-year SUD strategic plan. So this is different than the strategic plan that you hear Francis speak of. That is OCHN's large strategic plan. For the SUD department, we feed into OCHN's larger plan. But because of the federal funding that we receive, we are required to do a very specific needs assessment within the community every 3 years. And then we use that needs assessment to develop our 3-year strategic plan goals. And when it comes time to submit that strategic plan, it's all laid out and prescribed by MDHHS. They give us questions that we're required to answer, and that format doesn't change. And how that differs is with OCHN's large strategic plan, we have a lot of freedom in our needs assessment to develop the questions, change how we ask things, to try to engage people more. The setup for SUD, it's just very different because it stems from federal funding that we receive. So it's very prescribed what we need to follow. Next slide. And then in terms of just talking about what a substance use disorder is, on this slide and the next slide, I just listed from the DSM-5 what you will find listed for what a substance use disorder is. I always like to say when I talk about opioid use disorder as alcohol use disorder, I use the broad term of SUD, substance use disorder, to encompass all substances that I'm speaking about. You can go to the next slide and the next slide. All right. So for this is our fiscal year 21 through 24. It's a primary drug of choice comparison chart that we did. And the data for this comes from our behavioral health treatment episode data set. It's also known in shorthand for what we say, we call it BH-TEDS. And essentially our BH-TEDS data, anyone who admits into a treatment program or discharges from a treatment program, they have to have a BH-TEDS done. And essentially it is a prescribed data collection that comes from MDHHS. We cannot change any of the categories. MDHHS says here's the demographic information that you're going to collect. And in order for a provider to be able to submit their claim for reimbursement, they have to have a clean BH-TEDS admissions and a clean discharge in the system. So this is where we get the data from to be able to identify what an individual's drug of choice is. We also can get their veteran status, living arrangements, how often they use race, ethnicity, gender, age, involvement with the criminal justice system, how many treatment episodes, and so that's just a few of the demographic area that it covers. But on this slide here, it's just doing a comparison against the 3 most widely used substances. Alcohol in our network, predominantly from as far back as I can remember, is the most widely used primary substance by individuals that they seek treatment for. Heroin is second, and cocaine or crack is third. So you're able to see, I have to hold mine up to see, you're able to see a comparison. It's staying pretty steady. We're not seeing significant, huge trends or shifts. A question that gets asked at times is more about amphetamines or hallucinogens, and are we seeing it come on the rise a little bit more? We see it slightly, and by slightly I mean it used to not register when we would do a percentage. It used to be like 0.8%, right? So it was such a small percent. Now we see it maybe as 3%. So do we see an increase in regards to that? Yes, but are we seeing giant spikes in terms of the substances that individuals report they're using? No, we're not seeing those significant spikes. Next slide. This is some more drilled down data for you currently in our system, and this is from March 2025, this data. So in the system, in the month of March, there were, at that exact moment, there was 1,145 individuals enrolled in SUD services. On the left-hand side, you can see the admission by level of care in months. So for that entire month, we had 379 people enroll into services, and it breaks down the service categories on the left. Also, what I find to be interesting, and it's as we talk about federal funding and all of that swirls in the air, we also break down and we can see on our back end for our entire network, how are people funded? We see the majority of people receive Healthy Michigan at a little over 600. 300 people have Medicaid, and about 183 hit our general fund, aka our SUD block grant funds. Next slide. For our funding sources, I am always one to talk about the vast array of funding sources that we have. We have many. I always refer to it as a jigsaw puzzle. We're always working to figure out, how do we piece together and make things happen. I want to just say in regards to these numbers, these are numbers that come off of in July when Finance presented the fiscal year 25 projected budget. These are where the numbers come from. This is not all encompassing of all our financials. So I want to make sure to say that. I just wanted to be able to give an overview of the allocation amounts. And again, this is not the totality of the entire SUD budget. So under our substance abuse block grant, substance abuse prevention treatment, there's actually like 3 different names for it, because why not have 3 different names for it? So you can hear it be referred to as SUGS. You might hear it be referred to as block grant, SABG, or also SAPT, which is Substance Abuse Prevention and Treatment. Why MDHHS has 3 names? They have 3 names. I typically am always going to refer to it as our SUD block grant, and you'll hear that from Finance as well. Our total allocation is a little over $5.3 million. I do want to notate that that includes our prevention funds, our treatment funds, as well as women's specialty dollars, our admin costs under block grant, tobacco and vaping specialty funding, state disability assistance. So there's about 4 or 5 different categories kind of up under that total number. And then also our PA2 dollars for this fiscal year, for fiscal year 25, it's about $5.5 million that we will be receiving. Next slide. All right, so going into our prevention services, I want to first point out you will have a handout within your packet. It starts off by saying the prevention services funded by OCHN grants covers all the Center for Substance Abuse Prevention CSAP strategies. It goes along with this slide. So I wanted to make sure that you really had a lot more details about our prevention services, how they operate, what is the basis of why we do what we do. So essentially in the prevention world, any prevention service that we provide must, underneath our block grant services that are being funded, must fall into one of these 6 categories, because that is the framework in which prevention operates. So to just take one of them and give you an example, so on here there's education. This strategy involves two-way communication and is distinguished from the information dissemination strategy by the fact that it interacts between the educator and facilitator, and the participants is the basis of its activities. So the examples are life skills, decision-making, refusal skills, EVPs, evidence-based programmings that hit on all of those things, classroom or small group discussions. So this is when our network provides evidence-based programs to kiddos in schools throughout the community. So this is how they hit on that one specific strategy. I'm not going to go through all 6 of them because it would be very time-consuming and long, but again, I do recommend that you read in detail each strategy that we have listed in here. Next slide. So our prevention network, it is made up of 12 prevention providers. They are all listed on the screen here. Also, again, provided in your handouts, there is a more detailed list of every single provider and the very specific services that they provide. I could probably spend an hour just talking on this slide alone. So we really wanted to make sure to condense it down, make sure you have the information you need to be able to read more in depth on our providers. But to just highlight a few areas for our providers, we have our Holly Area Coalition, so it's always important that we really cover as much of the county as possible. And a big part of that is always making sure we have that northern representation. So our Holly Area Community Coalition, their goal is to delay the initiation and reduce the likelihood of student drug use by assisting students in acquiring life skills and knowledge of the dangers of drug use. They achieve this through doing an evidence-based program. They do it after school. It's called BOTVIN. They also do Above the Influence, Asset Mentor, Safe Smart, and those are the programs that they utilize. I've had the privilege of going out and actually observing it probably about 2 months ago. We went out to do an audit and watch, and the kids were great. That day they were that I was observing, they were going over tobacco ads and asking the kids, let's look at what this ad is. What are the advertising strategies that they're using to try to, lure kids in to think this is cool? So that's a part of the BOTVIN programming they do. Also, one of our prevention providers, the Oakland County Health Division, they provide expert screenings, which is screening, brief intervention, and referral to treatment to individuals who come through the health division clinics. And then they also do vaping initiatives and evidence-based programming as well. They do Catch My Breath as well as the Michigan Model for Health for students around Oakland County. Also, what I provided as well, because I thought it would be incredibly helpful, there is a list in your packet of all the schools in Oakland County that either our prevention network is in or our coalitions that fall underneath our primary provider who oversees them. But these are all the schools that we are currently in right now. So it's a vast list. We always want more. We've been able to make some great connections, and we just got connected with the chief or the deputy superintendent for Oakland Schools, who was more than happy to say, let me help connect you with even more schools for your network for you to get into. Next slide. Our coalition network. So our alliance, So we have our prevention network, and we have our 12 providers in our prevention network that are providing the contracted services with us. Then we have our coalition network, and our coalition network sits under the umbrella of our prevention provider, the Alliance. So essentially, we contract with the Alliance to oversee all of our community coalitions, and so we have 21 coalitions in the community that represent 55 out of 66 of the cities that we have in Oakland County. So we have almost all representation across Oakland County. We're close for it being 100%. Until we reach 100%, we can consider this to be an area of improvement for us. But the intent with Coalition is for them to work really boots on the ground, and they're in the community. They provide services just like our prevention network does, and they provide those evidence-based programmings as well. Next slide. And then in terms of our evidence-based programming, this is a list of the examples of we call them EBPs, evidence-based programming. This is a list of some of the ones that we do. So for example, BOTVIN, that's one that you will hear get mentioned a lot, BOTVIN Life Skills. And what that is, the objectives are personal self-management skills. Students develop skills that enhance self-esteem, develop problem-solving skills, help reduce stress and anxiety, and manage anger. So a lot of it is, when you really look at why a kiddo starts using substances, especially at a young age. Well, yes, there's that educating them about substances in general, yes, but it's also teaching them that empowerment, that self-esteem, refusal skills, so that way they can feel confident in what they're doing. I think kids at times will turn to using because of a low self-esteem or poor self-esteem and think, I need to fit in, so this is what I need to do. So by teaching them the leadership skills at that age, it's helping to divert them from that path. Guiding Good Choices, that is a family program, so it's not just for students but for parents as well. And it's to promote health and well-being and managing conflict and anger. And then also, as I said, Catch My Breath is very specific for vaping. And next slide. So for our substance use disorder service, for our treatment services, we have our typical services that we offer. We have withdrawal management, which is essentially detox, where somebody goes to withdrawal from a substance that they're using. We have our residential treatment. That's where someone lives on site for up to 30 days to receive treatment. With both of those levels of care, we have peer recovery coaches that are employed on site to engage with individuals. So that peer recovery coach is someone with lived experience. The providers also have case managers who assist as well. We have 13 total treatment providers. Of that, 9 are outpatient. One of those outpatient is a state-designated women's specialty program. 3 outpatient providers provide MAT services, and the MAT services occur at 4 different locations. We have 2 domiciliary intensive outpatient locations, 1 domiciliary outpatient location, and 5 withdrawal management providers, and 7 short-term residential providers. Next slide. And then we have outpatient services. Underneath outpatient, you will find things like case management, peer recovery coach services. Again, when it comes to a person's services that receive the services they receive at an outpatient level of care, it's all dependent on what they would like. So they have the ability to have case management, they have the ability to have outpatient or to have peer recovery coach services, to receive health home services. It's all a matter of what a person says, yes, I want to receive this, or no, I'm not interested in that. Next slide. Then we have our recovery housing, where it is sober living that a person is able to stay at for typically, we will cover the cost for up to 90 days. We can exceed that a little bit depending upon need. And then, of course, our medication-assisted treatment. That is our medication-assisted treatment, also known as MAT services. We couple that with outpatient therapy as well, and the medications that are used are methadone, Suboxone, Vivitrol, or Sublocade. Next slide. And then, as I had mentioned earlier, we have women's specialty services. We have state-designated treatment services. We receive women's specialty dollars from the state specifically for people who are receiving this service. So at an outpatient level, it's Oakland Family Services. At our higher level of care for residential, it is Sacred Heart Clearview. So what makes this different is it's really looking at the caregiver and what is their need, and especially for whether it's a woman with children or it can also be the men who are the primary caregivers. Things that can be a barrier for someone to receive services are they need to, they don't have childcare to go into withdrawal management or residential. They can take their child to Clearview with them. When it comes to outpatient treatment, they provide transportation, so that way transportation isn't a barrier. Child care is provided, so a person can attend outpatient counseling. Child care is also provided at the withdrawal management and residential level of care as well. Next slide. So our sober support unit, you have heard us talk about this at length before. Essentially, one of the things I want to highlight is this is one of the first, and we were one of the first in the state to have this program, and really be able to offer people access to our higher level of care services 24 hours a day, 7 days a week. So that means on Christmas Day, New Year's Eve, New Year's Day, if somebody says, I want treatment, they have a safe place that they can go and be transferred over into services. The Sober Support Unit is staffed by EMTs to medically monitor individuals, and then peer recovery coaches to continue to engage with an individual. And when somebody comes in, typical time frame for them to go from the Sober Support Unit to treatment is typically 24 hours or less. We can have some snafus at times, things that are out of everyone's control. It's okay. Sometimes it happens, and we don't have it's hour 24, it's 24 hours and 1 minute, you've got to go off the unit now. Absolutely not. Sometimes, though, it might be they have a third-party insurance, and we are struggling to get the insurance benefits run, and we need to be able to see that to authorize the use of block grant funds. Next slide. And some of the data for the Sober Support Unit. Fiscal year 24, 1,299 individuals served. For fiscal year 25, as of 4/1, we're at 739. So we're expecting to probably exceed the number from last year, and that's a trend we've been seeing. We've continued to see the Sober Support Unit, the use, continue to go up and up each year. Total individuals served in the SSU from its inception of when it opened is 10,363, and there is a 96% follow-through to treatment. So when they come on the unit, 96% of those people who come on that unit are following through to that higher level of care treatment. Next slide. Also, we have our RISE Center. It's located at the Resource and Crisis Center. And really the intent of our RISE Center, it is meant to be a short-term case management emergent need for individuals. Essentially, somebody should be receiving their case management services at a provider, but you might have someone who I need only one or two things. I just need some simple help, right? It's not long-term. This is a service they can access. What's used the most for this is when we have people with third-party insurance come through our access system, and we need to identify what their insurance benefits are, so that way we can say, hey, are they underinsured? Can we fund them? And so the RISE Center will get their insurance benefits pulled. We're able to see if they're underinsured, so that way we can step in and help assist with funding. Next slide. So going right along that lines, we're the public safety net for the community. So for fiscal year 24, we assisted 394 individuals with services by using our block grant funds or our PA2 funds. So essentially, these are individuals who had a third-party insurance, whether it was through their job, through a parent, and just because people have third-party insurance doesn't mean they have good insurance, and it doesn't mean they can afford that insurance. I look at the benefits all day long. They have a $6,000 out-of-pocket max, 20% co-insurance. They have to meet the $3,000 deductible first, the amount of money somebody would have to pay even with that insurance to go into services. They cannot afford that. And that is where we're able to step in and assist them with funding. A dollar amount cost to attach ISH to it, we probably spend about $200,000 a year covering these types of services for individuals. Also, we use PA2 funds when I call them, we get funky cases, because every once in a while we get some funky cases. And what I mean by that is I can have an individual who might have Medicaid that we step in, and because of different, they can have different layers of insurance. So, for example, we have a veterans who has veterans benefits, who also has Medicaid, and they're seeking MAT services through us. Well, in terms of payer order, the veterans benefits are the primary payer. They should be going through the VA for services. And however, the challenge is the VA is telling them it's going to be a 3-month, 6-month wait before they can even get seen to be even considered for a service. And we're not going to make our veterans wait. We document the attempts that we've tried, that the wait is 6 months long. I can't use Medicaid because it's not the primary payer. It's the veterans benefits that's the primary payer. But I can use PA2 funds to then take care of that person and take care of our veterans. Next slide. So we have our jail MAT program. OCHN, we were the first in the state to create this program. This is a fantastic program. There were other jail programs that have done this in the past, but they did not offer all 3 FDA-approved medications. Methadone is always the challenge for some jails. So we were the first in the state and really led and pioneered the way of what a jail MAT program should look like. I still take calls. I just took a call a month ago. Region 10 asked me for, Region 10, which is more of the thumb, Lapeer County, Flint, Genesee. They asked for a meeting with me because they wanted to discuss our jail MAT program because they're trying to stand theirs up, and the state directed them to me and said they've been doing this for 7-8 years. They've got it down pat. Call Megan in Oakland. She'll gladly sit down with you. Currently, to date this year, let's see, we have had 93 individuals who are in county that have been serviced and 82 that are out of county. So it's a total of 175 individuals. Underneath those who are in county, we fund those individuals under PA2. It was previously under our state opioid response grant, but then we lost, MDHHS cut our state opioid response grant by more than half. So we brought it to the board. It was approved to be under PA2. The MAT expansion program, as we call it, those are the out-of-county individuals. Oakland County funds that using opioid settlement dollars. But for uniformity, they asked us to oversee the program in the same way we're overseeing the in-county individuals, and they pass through the funds to us to then disperse to our provider in the jail. Next slide. One of my, and I'm partial to this one, this is one of my favorite initiatives, our Save a Life Station. So underneath our state opioid response grant, we get $850,000 a year. Our Save a Life Stations, we have made an incredible difference in the communities with these stations. The preliminary, and I don't even think it's preliminary anymore, the data that came out from the medical examiner's office is for, and you can go to the next slide. As I'm talking about the data, we can look at the data. For fiscal year 24, we had 164 total fatal overdoses in Oakland County. we had a 37.6% reduction in fatal overdoses when compared to fiscal year 23. That is incredible. And I truly believe that our initiative with the Save a Life stations and our partnership with our provider, the Alliance, who oversees it, I truly believe this is a huge part of it. Our numbers, so before we did the Save a Life stations in 2022, before we did the Save a Life stations, we distributed 3,430 Narcan kits for the fiscal year. In fiscal year 24, from January to September, so it's not even a full year. We're just looking at January to September, 26,000 Narcan kits were distributed. It is incredible the amount of Narcan we are getting out there. The boxes also contain fentanyl testing strips for people to test their drugs to see if fentanyl is present. There's xylazine testing strips, resources. I can't say enough great things about this initiative and the impact we're having on deaths and the overdose deaths in this community. Next slide. Our ARPA grant. So we received an ARPA grant from MDHHS. We receive it's $949,000 and some change is what we receive each year. Unfortunately, this year in March, the federal government put a stop to that funding. So where it stands right now is that there was 23 states that brought lawsuits against the federal government for stopping the grant and they're saying that it was done unlawfully. A judge issued a temporary restraining order against the federal government from being able to completely stop this grant. They had a hearing last week to discuss how this is moving forward, and there are briefs due on the 28th of this month for the judge to continue to take under consideration. It is hopeful that an injunction could occur, meaning that the judge could say to the federal government, you're not allowed to stop it, you have not shown cause, and we may receive that funding back, but we can't plan for that. So where it stands right now, projects we had under ARPA, we have some of our evidence-based programming that was specific to the LGBTQIA population that has been discontinued. The Michigan Model for Health curriculum has been discontinued. One of my saddest ones that I keep saying, Trish, but can't we? We provided summer camps in the summer for kids around Oakland County. We were going to be funding that under our ARPA grant, and so probably about 250 kids won't be able to receive that camp this summer now. We also had staff that was under there, marketing, advertising, and events, but I do have to say a big well done to the communications and finance team. We knew the stop order was coming from the state, and so everyone in this organization pivoted. And while we might not be able to, like summer mini camps, that happens this summer, we can't submit the expenses right now. But the marketing, advertising, and events, they pushed through $200,000 worth of invoices in 2 days to get paid out. So that way it could fall underneath the ARPA funding still, and we wouldn't be left saying, now what, with that $200,000. Then also our health home costs for no insurance individuals. So currently we've had to make the switch to our health home, only covering individuals who have Medicaid right now. Next slide. Our recovery incentives pilot, I've gone over this in the past. It's the contingency management program. It actually has not fully stood up yet because of challenges and delays on the state's part and the incentives management platform. But this is something that should be starting this summer. Next slide. And then our opioid settlement funds. So we received $1 million in opioid settlement funds that was written into the Michigan legislation. We did a request for information that was issued to our network that had a close date of April 4th. We gave them guidelines, we gave them budgets, and said, what would be the use of the funds that you would want to do. And so they submitted those back to us, essentially at a high level, because obviously with opioid settlement money, there's kind of money coming in all over the place, not to us, but to other, not to us, but to other people, so to kind of give you the lay of the land. So the opioid settlement money that's coming in, $38 million is going to Oakland County specifically, and then any municipality, township, city that joined in on that lawsuit, they are also receiving a specific dollar amount. The state of Michigan is receiving about $448 million directly of opioid settlement money. So altogether, it's, I think right now we're at like a little over $900 million, but I know that there's still some pending lawsuits, so we could probably even go higher. So that's where the money's going into. Now, being the PIHPs, the ones that are actually delivering the services and overseeing the services, the legislation, the Michigan legislation wrote it into the budget that each PIHP would receive $1 million. So that is where our $1 million comes from. Now, what makes it different than the county money, the state money, and the municipality money is that MDHHS has said to us, here are 8 bullet points of what you're allowed to use the money on, whereas everybody else has a 15-page document that they're able to, where there's a huge list of allowable activities. So, for example, our ARPA funds. When we lost our ARPA funding, the first thing I did was contact the state and say, can you allocate opioid settlement money to us to make up for the ARPA loss? And they came back and said, no, we won't. And I said, okay, can we use part of our $1 million of our opioid settlement money to make up for our ARPA loss? They said, no, you can't. And it's something to bring to light and make sure everyone's aware of. We have a lot of advocacy to do around this still. And the challenges we face with it at times, there is a system in place in the state of Michigan to assist the most vulnerable population and the people who are at the highest need, and that's the PIHP system. And we are underfunded by the state. We're underfunded by the state for SUD services. We're underfunded by the state for mental health services. And the state is the most flush with SUD money with over $400 million that they've ever been. And they are not pushing that down to the PIHP system for all of the funding cuts we're taking, for all of the challenges that we're facing, for the fact that we're underfunded, and we ask every year, can we use PA2 dollars for these prevention services or treatment services because we're underfunded. And so that's an area that we're continuing to work on all the time and talk to them about and work with Francis on, and Dana works with the other PIHPs on, because there is a lot of money that's out there and our system is hurting and we're facing more challenges that could be coming. And so for the board to be aware of and any advocacy that you are aware of or that you do, just know that we are out there as well. And it's an area that everyone needs to be aware of. An important area to highlight, I am not one to toot my own horn, but it is really important that I just share how great our partnership is with Oakland County. So we have 10 PIHPs in the state of Michigan. I am the only director for the state of Michigan that is working with any municipality, county, or township. And I was appointed by Executive Dave Coulter to sit on Oakland County's Opioid Settlement Steering Committee. The other 9 PIHPs, they have struggled to build that relationship with their community partners who are receiving those funds. So it's just a strong testament to the relationship we have with our county officials. And they saw the importance, and they know the knowledge that we can bring, the needs assessment that I brought up earlier. That needs assessment is what we can share with them to say, we've done the work, we have the data for you, here it is. And next slide. That is it. I will happily take your questions. Yes, Doug.
I just want to say I think you're doing a great job. I'm really, really impressed.
Thank you.
Okay, so hopefully I'm not reinventing the wheel since I'm brand new here. The one slide that talked about the substance of choice, or whatever the title was, and it mentioned heroin. Is that including all opiates or just specifically heroin?
I have to look at my notes. So on it, because we're talking about the DSM slides, right?
Yeah, this one with the...
So, that specific one, the bar graph,
yeah,
specifically it's talking about only heroin.
Only heroin.
Yep.
Okay. Do we have data on opiates generally and...
How they classify it, and if I'm remembering correctly, heroin is one category. Oh, I don't want to misspeak. They have it broken down into different categories. I think we have a category that's called like other opioids.
Okay.
So we have our heroin category and then we have our other opioids, but I can look at the specific BH-TEDs and let you know the specific, I know it's more than one. Does that make sense?
Yeah, and then possibly the good news is that other opioids don't hit the top three.
Yeah.
So
They don't.
Good. And then without to approach you mentioned about VA, that veterans are supposed to go to VA first. We don't have a VA facility in Oakland County, do we?
Not that I'm aware of, no.
There's Wayne County, and then there's Washtenaw. Right.
Yep.
So, and then Medicaid funding for jail, do you have any insight on what's happening with that?
I do have insight. See, I am full of information. I could talk for so long up here and tell you so much more, but I'm like, I can't. I need to shorten this. So the Medicaid for the jail population, oh goodness, we're in 2025 right now. Forgive me because my notes aren't in front of me. So the state of Michigan is putting that it's being put underneath the 1115 waiver, so underneath the Medicaid waiver, where the intent is for Medicaid to start in jail or prison 90 days before a person's release. And that's useful for a lot of reasons. One, so that way costs that a person is receiving services can go to Medicaid, but then two, that care coordination when they leave. So essentially right now, Dr. Pozios sits on a part of the state work group that is being done to talk about the rollout of this. I'm his backup if he happens to not be available to attend. The state is proposing a 3-phase rollout of this. Forgive me, I can't remember the first year they say it would start, but they're saying child caring institutes and prisons would be phase 1, jails phase 2, everyone else phase 3. So we would have a little bit of time still till it hit the Oakland County Jail, but me being me, and I can't help myself, at the last state call that I was on, I very happily volunteered Oakland County, and I informed the state Oakland County Jail would be very happy to be your one pilot case in your phase 1, because you're going to need somebody who's been around and doing this for a while, and that's our jail, so we can pilot it and get all the kinks out for you. And I told Oakland County afterwards that I voluntold us, and they were fine with it.
Cool. Excellent.
Yes.
Where the funding for Save a Life, was that ARPA dollars?
The Save a Life stations fall underneath the state opioid response grant.
Okay, so not going to sunset with ARPA.
Nope.
Excellent. Perfect. And then last, I'll go there since it involves me. Oakland County, other than potential pass-through funding coming from the state or feds, Oakland County doesn't have a line item in their budget for OCHN, do they?
Are you talking about opioid settlement money specifically?
Okay, well, let's set aside all of those various pools of money that are easy to hand out.
Yep.
We don't, in our general fund, we're not giving money to OCHN to do their programming, other than the stuff that's passing. I don't,
I want to say I know and Trish knows this better than me.
Phone a friend.
You're venturing out of my SUD category right now, but Trish knows.
I'm gearing up for advocacy here. So.
I'm so excited this is your first meeting. I'm so glad you're here, Ann. And I know our CFO is online too, but we do receive general fund from Oakland County.
Okay, good.
It's probably approximately $9 million a year. It's been that way since the 90s of what we receive from there. So, and Rob, or even maybe Nian, can talk more about specifics, but I believe I'm right around that right.
My thinking cap is switched on, remembering now that the 9 million has been the same 9 million forever.
Yes.
Okay.
Usually I say since some of us were in high school, so. But yeah,
It's a good way to
we
put
work
it.
very closely, obviously, with the Board of Commissioners.
Right.
And then the general fund obviously supports non-Medicaid activities for that.
Okay. All right. Good to know as we're going into budgeting season.
And just to come back and answer your question, thank you, Anna, who has her computer and could bring up the BH-TEDs to me. There's 3 categories. So there's heroin, non-prescription methadone, and then other opiates / synthetic opiates.
I had a question regarding the women's specialty services. Is a person required to identify as either male or female in order to access those services?
No, they are not, and that is thanks to all the advocacy we've done. BH-TEDs used to require someone to identify as male or female, and while MDHHS also believes in people's choice and things like that, it takes a lot for it to get changed. It's not easy, but through continued discussions and advocating with them, they did finally change it. So the system has a complete drop-down of choices in which someone can identify as.
Any other questions?
Yes. Hi.
Yes.
First of all, great job. In general, and on this presentation, I know there was a lot that you did, and you're doing a great job. So I've been here a couple of years, and you're just getting better and better. So thank you.
Thank you.
3 quick questions.
Yes.
The recovery housing. Does the individual have to go through our inpatient rehab through us, or they could just come from anywhere?
Yep, they can come from anywhere. 9 times out of 10, if we look at the utilization and we run the data, probably 90% of people are coming from a treatment center. That does not mean they have to. So somebody could be living at home, it's an unhealthy environment, mom and dad are using, could be any of those things, or they're not being supported. Anything like that, and they can call recovery housing directly and say, I want to be able to come in, I need a sober environment, I need to build my recovery network, and they can absolutely do that.
That's great. And where's that run out of? The same place as Common Ground? Access, or it's separate than Access?
Separate. So in terms of somebody accessing the recovery housing, they don't need to go through Access. They can call our recovery houses directly. They don't require an Access screening.
Could someone provide me that number or that contact info? I don't have it.
Yes, we can make sure, Suzanne, will you make sure to send out our brochure and it has our all of our different recovery houses listed in there. So we have Turning Point, Milford, and Sacred Heart. Those are our 3 contracted providers, and we'll be putting out an RFP, a request for proposals, shortly, specifically to specialize. We want to bring a recovery house on specifically for people who are receiving methadone services, because that's a challenge, and then also for people with kids.
Mm-hmm. So speaking with, thank you for that, people with kids, one of the, who is running the inpatient for women with children?
Sacred Heart.
So that's the only one that we're working, okay.
Yes, and we call it's Sacred Heart. It's also called Clearview, though, and that's how they...
There you go. Okay.
Yep, that's how they differentiate it from their kind of regular program, and their women's specialty program is the Clearview program.
Got it.
Yes.
Great. One last question. I'll try to make
Yes.
it. The Botvin life skills.
Yes.
So I was listening to what it entails.
Mm-hmm.
It sounds like something they would be teaching in school anyhow. So what am I missing?
So when it comes to any of the EBPs, it's a specific curriculum, and it is required in order for it to be effective. You have to follow the fidelity of the programming, and that means there's a workbook that comes with it. There's handouts. So, for example, when they were doing the smoking advertising, it comes with all of the information, and they're required to go through and do it. And you'd be shocked and amazed, because it's not required out of every school to provide that type of service. Schools are required, and this is actually a conversation I just had with the Deputy Assistant Superintendent. Schools are required to have their health class. They provide basic health basic health information. That's it. That's all they're required to do by the state. So not every school has the ability to be able to do that, and to do it in a way that we pay for everything. Oh, that scared me. We pay for everything. So the staffing is paid for, the programming is paid for, all those components are paid for. It's not something that the school is paying for in any way. They have zero cost for any of these services.
Okay. Thank you. Appreciate it.
Okay. Yes.
All right. I just kind of want to, he was talking about the Sacred Heart and the Clearview. Are those preventative or no? Those are recovery. And are those the, like, inpatient? I was just thinking of one of the places that takes kids and they take them to school.
Yep. And so that is Clearview. So they have the bus that comes around. So for kids who are school age, they make sure the kids get off to school. For those who can't go to school, they have the daycare on site for the residential treatment. It's treatment services, but then really what they work to do when the person is there is to teach them the skills that they weren't ever taught before. And so some of that is preventative, right? They're kind of receiving it after the fact, but they were never taught that to begin with because most likely the environment they grew up in. And then in terms of at the outpatient level, we provide OFS with funds to do specific outreach for women's specialty as well to try to get that buy-in engagement, so that preventative piece is, partly there, if you will.
Okay, thanks.
Yes.
And then I'm just curious about other ways you do the preventative, like how do you go into schools, or how do you do
for the prevention program?
Prevention,
yes. Most of the prevention program, it's delivered by either the prevention providers or the coalitions, and they're most likely linked in with the schools. You have the very large school list that's there. Other things they do are the summer camps. So while, yes, they're doing a 2-week summer camp, they're doing fun things. They're having water balloon fights, but then a part of that summer camp is the Botman Life Skills program that they have to do for 30 minutes a day, and then they can do all the other fun stuff as well. So they're getting that programming, with the other fun pieces. But, yes, mainly it's a lot of the things are done within the school. Catholic Charities, who came probably a couple months ago and presented to the board, they do things at their offices. They provide mentoring. They provide things after school that are done. So while 70%, and that might be a little high, of things take place in a school, there's also a large amount of things that do take place outside of school.
Okay, thank you.
All right. Thank you. We're gonna, if there's any more questions, please save them to the end if there's time, or we'll table it till next meeting because we are 20 minutes behind. All right, quarterly financial update. Is this Nian? Are you presenting? Okay.
Thank you. Good afternoon, Board. Nian Bland, Director of Financial Planning and Analytics in the Budget and Finance Department. Okay. So I believe that everyone does have handouts as well, some of the information, because it is kind of large and the formatting is a little small. So if you do, thank you, and let's get into it. We'll start off with the first slide that goes over our FY25 Q2 budgeted projections. This is the revenue, and some things I'd like to bring your attention to. We are looking at the revenue that is based off of our initial FY25 budget forecasting and projections. We have not done many updates to this at this point. In red, you will see in the far right column, there is a number for the recovery incentives and fractions funding source. It's listed at $109,150. That's an increase from the initial budget, which stated $15,000. So we received about $94,000 additional dollars there. I also like to bring your attention to the annual projected budget is calendarized. We are looking at 12 months, and our columns indicate, so we align with our expenditures the first 5 months of our fiscal year, October through February, and then the remaining 7, okay? So from there, I also like to bring to your attention just some general housekeeping for our revenues, that the block grant, prevention, SOAR, SDA, treatment ARPA, prevention ARPA, and recovery incentive and fractions are all based off of our state allocations. All other funding are based off of projections from FY24. So there may be just a little difference in the numbers that Megan presented during her presentation and what you see here, okay? The variance is not significant. There are 2 funds that are not listed in this revenue projection here. It is $224,000 for the alcohol use disorder treatment, and then there is the $1 million for the healing and recovery community engagement and infractions. Both of these funding sources will be listed in our next presentation with activity that follows, okay? Moving to the next slide, please. So we're going to go through the expenditures, and there's a few things I'd like to note that we projected and forecasted a full year of FY25. We did this by using our first 5 months actual, that's October through February, and then we annualized that for the remaining 7 months of our fiscal year. Those are the 2 columns that you see in front of you or listed on the papers in front of you, and then the 4-year projection. This is normal for our past year's presentation in our interim quarterly meetings, board meetings, until we get to the final, which we produce the full year actuals, okay? I'd like to also bring to your attention that our SOAR fundings decreased. I know Megan went through this as well, but we usually had about $2 million in SOAR funding, and for FY25, that was decreased to $850,000, okay? I won't get into a lot of the programmatic part of this and the reallocation of those funds, but just know that those programs that will continue have been moved to the block grant line items here, and any other programming will be absorbed by our PA2 funding. Okay? Next slide, please. Okay, let's get into our net position here. So I'd like to bring your eyes down to a few things here. For the full year projection, our surplus deficit, we're coming in about $85,000. Now, I'd like you to note that in red are the line items or funding streams that have a large impact on our budget and what needs to be covered or absorbed by PA2 funds. The line items that are in blue are minor in their impact, and they go along with what would be covered or absorbed by PA2 funding for any overages, okay? If we sum all of these, we come to about $3.5 million. I'd like to bring your eyes down to the PA2 line item, which shows a surplus or a net position of approximately $2.8 million. Okay, and that's the funds that we're looking at when I talk about absorbed or coverage. So the difference between that 3.5 and that 2.8 is approximately $600,000. Now, I want to remind everybody that this is based off of forecasting. So if we follow the trend that we're currently on for activity expenditures, this is where we will find ourselves. What we've seen in the past few years is that this kind of levels out throughout the year for cyclical activity. But I want to, again, draw your eyes down to the final line here, which is about $85,000, that if necessary and if this trend does continue, we might be looking at requesting above our approved $4 million for PA fund expenditures. Is that tracked? I hope so. Okay, next slide. Our next slide actually does a year-over-year comparison. This says 3 years here, but it's the 3 years with the fourth year projection. I'll get that corrected here. And again, this just lets you know that as we have moved year or advanced year over year, our net position has changed, and there's different reasons to what caused those changes and where we have supplemented the differences in funding by our PA2 funds. This was a request of the board to have as a continuing standing presentation and report. Next slide. Okay, so here we have our 5-year PA2 balances, and unfortunately, as an IER, the last FY24 is cut off here. So I'll verbally go through it and note that it will be reflected in the next board meeting, and the corrections will be sent to our admin staffing for updates. So for FY24, we begin our year with the $10,484,265 that we ended in FY23 with. Our revenues totaled $5,496,980. Our expenditures was the 4.3 that was approved by the budget, by the board, and that gives us a net position, a net change of $1,196,980, with an ending net position balance of $11,681,245. So again, the verbal presentation of that information will be updated for the next meeting and also for the DAC here. This concludes my presentation, and if there's any questions, I'll take them, welcome them. Suggestions?
I don't have a question. I do have a suggestion. Sometimes I get lost in the numbers, so maybe next time you come, you could have use a pointer so that, like that 11 million, I didn't know where, was it on the same page, or I just couldn't find it.
Noted, that's good. And then it's not on the page. Okay. It was actually off of the deck, and so it didn't fall into the slides that you see here. It's a formatting issue on my part. Moving a little fast, my apologies, but that'll be updated. Okay, great point. That was a total verbal. Okay, thanks. Any others?
Anyone else? All right, thank you.
You're welcome. Thank you, everyone.
All right, next on the agenda, we had the OPB bylaws revision approval. Well, Bernard is not here, and I am not prepared to review all of the changes.
Hi there. So Bernard is unable to attend the meeting today, so we just ask that you just review the changes, provide any insight, if this board could provide any insight, and then go for approval at the next board meeting, if that's acceptable.
It is. I don't know if we were going to review them right now. I guess I'm not exactly prepared with what was changing. But
so if you guys can review them and then provide any insight during the prior to the next meeting, and then you can review them in full, the suggested changes.
That'd be perfect.
Okay, thank you.
Yeah, that's what we'll do. Yeah, so we're going to table that till next meeting, as stated, and please review them if you haven't already. We've had this for the past few meetings, so hopefully everyone's looked at them already. It's not nothing too major being changed. Now for the training plan, which also had been tabled from before. Tricia.
Hello, Tricia Zizembo, Chief Operating Officer here at Oakland Community Health Network. I know we have a couple slides just to review, and then I'm going to share my screen a little bit to give you a walkthrough. So just some background, mirroring off what our we call it our big board, our OCHN Board of Directors training plan is. We have mirrored this to help educate board members so that they are fully prepared. A little bit what I was thinking of when Megan was presenting, like, that is what I need for my deep dive in SUD, so that's already created. And this would be on an every 2-year basis. This would also help educate you on SUD rights, which is very different than our mental health rights. Board member responsibilities, that was a big discussion we had at a prior meeting on very specific on what is the board responsible for, the different positions on the board, how often they reoccur. So if you go to the next slide, it also continues with some training on rights, HIPAA and 42 CFR, which is very specific to SUD, conflict of interest form, which is an attestation, along with some corporate compliance, DEI, which is all required of our larger board as well. And so we had discussed this prior, and then we are utilizing our learning management system called Docebo, which is where we have all of our board members educated through. So they're online trainings that you can take on your own time, and then the system will automatically remind you every year, every 2 years, that you are up for renewal. So I took a couple screenshots of what the platform looks like for the next couple of slides, and I'll let Kara get through kind of what it kind of looks like, and then I'm going to actually show you in real time what some of the trainings are, what are some that I still have in draft to show you as well, and then we can get feedback. My goal is to have this complete and launched at our July meeting, so then the board would have until the October meeting to complete. So don't tell the other board I give them 30 days to complete it. I will be giving you 90, but this is the first time that we're doing this, and there's a little bit of a learning curve, but it is pretty easy. Everybody's already in the system. I've already put you all in, given you all a password. You'll be prompted to change that password when you log in, but based on our prior conversation, it really helps to make sure that you are informed and knowledgeable as a board member for when you are making and voting on your decisions. So if you're ready, Kara, I can jump on. I am just going to take over here and make sure that everybody can see my screen. All right. So everybody will have a login. So you'll put in your email, you'll create your password, and you will join, and this is what you will see. It'll say right up here, this is the OCHN OPB homepage. You'll see your name and login right here. There is a tour of Docebo, which will walk you through a link. It'll kind of show you the whole learning management system. If you've used the learning management system, it's fairly user-friendly. There's a reason we picked this. Our entire staff is on it, our board members, all of our direct support professionals, and we will eventually be launching this out to our providers as well. So everybody will start by joining the new board member. So because we're all new at this point with the training, and you would click Start Learning, and this is what everybody will see. And it's going to seem a little overwhelming at first because you are going to see, Kelly's like, hold on. This is a little bit because I have multiples in here. So I have our board, I have this board, I have a little bit here. But what you're seeing is the first one is called a learning plan. I liken that to a book, right? And within that book is each e-learning training. So you'll have multiple trainings within a learning plan. You can filter this out, and we're just going to filter it by learning plan so that you can see these are the learning plans that I have. It makes it a little bit cleaner. You are only going to see one. You are going to see this Oversight Policy Board right here. And when you click in there, you will see, I like to call it the chapters within the book. So the different trainings that are in the learning plan. So these are the ones that we have in right now. We have 3 more to enter, which we'll cover on that list that we went over when I first started. But I wanted to kind of give you an idea of what they looked like. They're all self-study, so you go at your own pace. So please do not let the hour and 30 minutes under corporate compliance sway you. That is an estimate based on if somebody is maybe reading it aloud or if there's others. All of these trainings you can leave and come back to, and they will bring you back to the spot you were at. And a lot of them, again, depends on how fast of a reader you are, how you peruse the training. So I am just going to click to resume this one so you can kind of have an idea. There'll be a description down here you'll be able to see. And because I've already taken all of these trainings multiple times, it will give you a little idea of what it looks like. And again, you will scroll through. There is some reading. We use a lot of acronyms in our whole field. And so this will be able to give you a little bit up there. And again, there'll be images. Some of them may have videos embedded. We want to make them as engaging and interactive as possible. So I just want to give you a little bit of that. I do want to go back to the home page. Once you finish your trainings and you get the alert that, hey, your 1 year, your 2 years is up and you have to take them again, when you log back in, you're going to come back to resume learning. And this is where it's going to take you, and you will be able to see a little different view of what trainings need to be renewed. And then you would click renew now, and it will join you in the training. You are able to kind of navigate the platform yourself. Down here, it will also set so you'll see that what you need to be renewed right up front as well, and you can click that if you don't want to go through resume learning. Up in the user menu, you'll be able to, once you log in and you see your activities, you'd be able to see that here as well. And then I do want to give you a little bit of an overview of what the trainings I have in draft. So these are in draft form. We use a software to make our e-learning trainings for you, but just as a kind of behind the scenes, if anybody is interested in this kind of stuff the way that I am. This is, again, modeled off of our OCHN board and what the responsibilities will be. And this is where we create and customize some of those trainings. We have just begun to update, well, we're almost finished updating the OCHN board orientation. That gives you the whole overview of who OCHN is, a little Finance 101. We will be using that as a copy and adding in what Megan just did for this board to give you more of a deeper dive into SUD, so that way you're updated on a regular basis in new boards. So you will see a little bit about what will be in board member responsibilities. It will have your bylaws that are in there. So your bylaws as they are now, I have put in there. Once you approve your updates, I will update this in the training. You'll attest that you've read and understand the bylaws, and then you can learn about what the board chair responsibilities are, governance, ethical behavior, and then attesting that you have read and understand what your responsibility is as a board member. So that is a little bit of an overview, and I won't stop sharing yet if anybody has additional questions on the platform or on the trainings. Again, this isn't meant to be, 8 hours of training or anything like that. This is meant to provide you with the knowledge and education that you need to make the decisions as a board. So I'll open it up for any questions, thoughts. Everybody is so excited for training, you're speechless. I love it. Thank you. And again, I'll stop sharing here, but I will come in July as well. I will have a handout for you that will walk you through the steps of how to log in. It's very easy. I'll set it up with a QR code. You will already have a login, and you'll just be prompted to choose your own password when you get there. And when you log in, you will see that learning plan. But I will be here for that meeting and be able to walk anybody through that. You'll be able to contact us if you need help. But I will have those instructions printed out for you as well.
All right, were there any questions? No, I don't remember, were we supposed to vote on approving this, or it's just given to us?
I think the intent was to present it to the board. I don't know necessarily, and that's really, I think, maybe your guys' choice. I don't know if approval was needed, but really wanted the board to be able to see it, understand it. When we've had some new board members start recently, there was conversation of people being able to be better informed and understand their role, and so that's really the intent of it. And all the board members, when it was talked about last, they said, yeah, let's see this, and I think this is probably a pretty good idea.
And Sheila can probably fill in as well, but for our larger board, it is built into their bylaws that there is training and orientation. It's worded very broadly, around
Right,
training.
that's why I
Yeah.
asked, because I don't think it's in
Yeah.
our bylaws, so I didn't know.
And that might be a suggestion that you could make
Right.
to vote on for next time.
Right.
Yeah.
Okay. Okay. Any further questions before we move? All right, thank you.
Thank you.
All right, new business. Could I get a motion to approve the minutes from the January meeting? Second? Can I get a second? All those in favor? Opposed? Motion passes. We have one vacant board position or two? I think just one. One vacant board position. If you know anyone from the community with affiliation with faith or with SUD type services, mental health services, anyone who is interested in joining, please direct them to the website. There's a form to fill out. Oversight Policy Board member issues and announcements. Did anyone on the board have anything else? All right, thank you. Any comment from the public? All right, with that said, meeting adjourned.